Guidelines Committee for several years. That's the extent of my knowledge of it, but I've become more and more involved. I've got to rewrite a few, and I'm very interested in furthering my knowledge.
Jason Kuhn. I'm an assistant professor of surgery at St. Louis University. This is my first time on the Guidelines Committee. No experience writing guidelines. Excited.
Ray Price. I didn't have any experience with this until I came on the committee, but probably the longest person on the committee from about 1993 or 94. Wow. You're not alone, right? But I have a lot to learn about how we do this, so I'm excited to be here. I'm from Salt Lake City, general surgery, healthcare, and also the University of California.
I'm Danielle Walsh. I'm a pediatric surgeon at East Carolina University, and I did the pediatric component to the peritoneal dialysis guidelines. And we have plans for writing. There are actually very little in the pediatric surgical literature about it. So there's several pediatric surgeons here because we're very interested in not only contributing PEDS components to the adult guidelines, but also writing our own for the procedures we do independently.
Stefan Scholz, I'm also a pediatric surgeon in Pittsburgh, actually. And I'm participating in writing guidelines for the pediatric part of the splenectomy guidelines. I'm kind of a guest here.
Bill Richardson, I'm the chair of guidelines, and I've been on guidelines almost as long as Ray has, but not quite.
Dinesh Stefanidis, I guess we've been in touch. I've also been a while on the guidelines committee, and I think I've learned a lot through the years, but the one thing I learned a lot more of is how much I did not know. So that's how the initiative came about, to really engage someone who hopefully knows more than we do to bring us to the next level. Thank you so much for coming today. Cynthia?
I'm Cynthia Zarate. I'm your project coordinator. I'm the person you receive all the emails from. Nice to see you.
I'm Giovanni Rapri from Brussels, Belgium, and I reached the committee 2 years ago, and actually I'm in a group working on guidelines for splenectomy.
I'm Steve Haggerty. I work in the northern suburbs of Chicago, North Shore University Health System. We're affiliated with U of C. I've been on the committee since about 2005 or 6, and I've been on 3 published guidelines, but I've really appreciated the sort of change in how we're doing things and what Demetrius has kind of set down. So excited about your talk and how it's going to look from here going forward.
Jeff Conn from Melbourne, Australia, affiliated with Monash University. I've been on the Guidelines Committee since the bariatric guidelines back in 2008, 2009, which is my first experience with guidelines. And since then, similar to Demetrius, I've realised there's a lot of don't know, and there's more to a systematic review than perhaps we knew when we started, and the guidelines now I think are becoming much more robust, and I'm very excited to be in the process of a very good quality guideline that's up there with the best out of the best organisations in the world.
My name is Jörg Zehebner. I'm a surgeon in Los Angeles at the University of Southern California, and Jeff brought me to this committee 3 years ago before they had hernia guidelines, and I'm happy to be part of. I have to apologize that I was not here on Tuesday for a family issue, this meeting, and I have we have a talk at 8:30, so I have to leave as well now, so thank you.
So Wayne Overby from the University of North Carolina, came on the Guidelines Committee in 2005. Probably the 2 biggest ones I've been involved with were the bariatric surgery guideline with Stephen and Jeff, and then the biliary tract surgery guideline. And I think I would echo what's been said about how much things have changed since I started to now, and I would also say I'm very excited to learn more and to sort of move to the next level in terms of doing quality systematic reviews. So it's and the other thing I would say, and I said this to Demetrius tonight, is that it's exciting to see the leadership of the society finally getting behind us in more than a token way. So that's brand new. That hasn't happened since I've been here. So that's really exciting.
I'm Leanne Feldman from Montreal, and I've been on and off this committee for a long time, and again seen it kind of progress. And I've been involved in some systematic reviews, but I've never really been involved at a high level in the kind of, following guidelines to write guidelines. I think I'm looking forward to it.
Great. It's nice to meet you also. I'm Ethan Balk. I'm an internist by training and went back and did some methodology research and started to work on systematic reviews and guideline development in about 1999, so I've been doing this for about 15 years. Most of my work revolves around systematic reviews, the methodology of it, conducting them, improving the methods. I've worked with the National Kidney Foundation for about 8 or 9 years in producing their KDOQI and KDIGO guidelines, which are very extensive, large-scale, all-encompassing guidelines. And then from there also have worked with a number of other societies on producing more focused guidelines, which I think are probably more similar to the work you've done. Some of the projects that we've done, our group has done essentially all the kind of detailed work, and then with the guideline development groups, work with them to turn those systematic reviews into recommendations. But more frequently, I've worked with groups following the process that I believe will happen here, where we provide some support and guidance in helping you to actually do the work to do the systematic reviews and the guidelines. It's a major focus of mine to link up the systematic reviews with the recommendations, and so I think it'll probably be a good thing for going forward for your guidelines to show that direct linkage, show where you have the evidence, where there is evidence to support recommendations, show where evidence is lacking, future research is needed, where recommendations can still be made, but be transparent about the level of evidence. So I'm going to go through a number of slides about practice guidelines and systematic review development, but I'm hoping that this is really more of a discussion and that I won't just be talking for 3 hours. Whoever is in charge of these things, please let me know when we should take some breaks and such.
Sure.
It just
Chris
keeps going.
doesn't need any breaks.
No breaks.
Yeah.
We're surgeons.
Okay, which way do I go? Okay. So I'll get you copies of these slides and other kind of handouts and cheat sheets and
So
and
Cynthia
forth.
can send that out to the committee if you
Yeah.
send it to them.
Excuse me, we have 2 guests on the phone as well.
Oh,
So I don't know if
Who's
you
on the
want-
phone? Oh, we need to turn it on?
yeah,
It's just you.
It doesn't look on.
yeah.
The green light is not on. How do I
No,
get
it isn't.
It's on.
Oh, it is
We
on.
are.
Hello, who we have on the phone?
They're very quiet.
Okay, did you check with them
Yeah,
earlier?
they were on. I'll check with them again.
Hello, guidelines. All right, well, you're missing out if you're not there. Right. We had somebody from Germany or Netherlands coming,
Yes.
right? All right.
Okay, so at least in this part of the talk, these are the things I'll be talking about: definition of the rationale for clinical practice guidelines, standards for trustworthy guidelines, the process and participants, and grading of evidence and recommendations and challenges and evidence of the system guideline development.
Just to introduce Rob Fanelli, he
Sorry to walk in late.
he was the chair of the committee until recently, so he has also extensive experience. So he'll probably be vocal about a few things.
That's amazing.
But that's important.
So yeah, and actually the other thing I was going to say about what I'm going to present is that I'm presenting some standards put together primarily by the Institute of Medicine, but this will really take a discussion about what's feasible for your group, what's realistic to be done, what's reasonable, what fits with your agenda, what the standards and the specifics about the methods are, for the most part, really just suggestions about how to do things. There are an infinite number of ways of doing things. I'll be talking more about the Institute of Medicine standards. They call them standards, but even within their group, they recognize that many of them are aspirations for the ideal guideline.
Why do you use them as the standard?
Well, for a number of reasons. One is that they're one of the few groups that have come together with representing a wide range of viewpoints, and also with numerous well-respected experts in the field, and who then comprehensively went through the whole guideline development process. And actually, at the same time, a separate group went through the systematic review development process and created standards for the international community to follow. And they're, with, I would say, few, if any, exceptions, good aspirations, good standards. Not all of them apply to all groups and all situations.
Is there a way through that they grade the guidelines in some way, or the guidelines can be graded?
There's not a formal process for that, at least with these standards per se. The National Library of Medicine, actually a group, an evidence-based practice center that was running or helping to organize the guidelines.gov website through the National Library of Medicine. They were charged with going through the Institute of Medicine standards and determining which of them are true standards that need to be implemented in order for these to be considered guidelines, and therefore make it up onto the guidelines.gov website. And after a very long process, actually about a year and a half or so, going through them all, discussing with various people, it ended up getting cut down to an extremely short list, which they probably could have written at the very beginning, which was basically that they had to be based, at least in part, on systematic review, and that their methods had to be available and transparent.
I think we participated because they send an assessment form and a guideline to review and assess it, and to comment on the assessment form, how appropriate it was.
My guess is that was based on something, on either the IOM standards or something similar to them.
We've been concerned about making sure that our guidelines are well written, because we don't want to be criticized and then feel badly about what we've come out, espousing. And the other thing is, we do want to be uploaded on some of these national and international sites, and we want to make sure that our guidelines are good enough for that.
Okay. Yeah, I'll be talking a little bit about that also.
I guess one of the things I've been interested in many years too is how we write our guidelines such that we're more usable and user-friendly as well. I have good guidelines, but a lot of guidelines out there that just aren't used. And
have something that's functional and usable and.
Yeah, that brings up a good point, and that's something that our group definitely tries to emphasize, that the recommendations themselves are not only evidence-based, but they're also actionable, that you can read them and know what should be done, in whom, in what situation, and what the caveats may be.
Well, we're not just here to write guidelines, we're here to make impact on healthcare, and that's, I think, what we really want to do.
And you don't want to make just bland, kind of feel-good statements. You want to, at the end of this, at the end of the process of doing the systematic review and writing the recommendations, the work group are the world's expert in that particular topic, and for the moment. And so, we encourage them to run with that and really write recommendations for the rest of the world that is not going to be able to put in the time and effort into looking at the evidence quite as well and thinking about what all the issues are. So, okay, I guess all of you have had experience with clinical practice guidelines. I wasn't really sure where people would be. So this should be pretty much straightforward. I mean, obviously, there's a process from evidence generation, doing the studies, synthesizing them, and then developing them into guidelines. And then, along the same lines of what we were just talking about, these guidelines, assuming that they're respected and people think that they're worthy, will be implemented. And part of that will be people, individual clinicians making decisions. Part of it will be patients and patient advocacy groups looking at them and seeing what they can do and what they can encourage clinicians to do. Part of it will be policymakers making decisions, all to improve practice in healthcare. So what are guidelines? This is from the Institute of Medicine standards report back in 2011. Clinical practice guidelines are statements that include recommendations intended to optimize patient care that are informed by a systematic review of evidence and an assessment of benefits and harms of alternative care options. So I think this covers a lot of what I've been talking about, adding in the concept of benefits and harms, and we'll be talking about that a lot. The outcomes of interest are both sides of the equations. Every intervention ideally helps, but also has a risk of harms of various types. So why do we do clinical practice guidelines? They describe appropriate care based on the best available scientific evidence and expert consensus. They should reduce inappropriate variation in practice. Some variation in practice is inevitable and probably appropriate, but a lot of it is inappropriate due to inadequate care or possibly arguably incorrect decisions being made. They can provide a more rational basis for decision-making, help people in their decision-making process, promote the efficient use of resources. Obviously, if inappropriate care is being given, that's a waste of resources. If interventions are being used that cause harms, that increases resources use. I'm sure you all know probably better than I do the environment that we're in these days, where keeping costs under control, not wasting things is a vital point. They can act as a focus for quality control, including auditing, performance, clinical performance measures. So again, the the strong recommendations that come out of the guidelines that are based on good evidence are frequently used, are turned into performance measures. Does is Sages actively involved in developing clinical performance measures?
Actually, there is a new initiative that is looking at this, yes. We're not actively currently doing
Not yet,
it, but
yeah.
we're looking at doing it.
So, presumably, that group, when it comes together, will be going back to your guidelines and as a basis to create those measures. They can provide a focus for continuing education, and importantly, they highlight the shortcomings of the existing literature and provide suggestions for future research. So that will be something that I'll be recommending to the work groups as they're writing up the recommendations and writing up the reports and manuscripts. That the section about future research actually be essentially evidence-based and specific and coherent, not just, we need more research on this, but this is what should be done, this is where the gaps are, these are the comparisons that are needed, these are the types of studies that should be done to fill those gaps. And the whole systematic review process and the discussions that come out of that in the creation of the recommendations helps to inform that thought process. This is an old Venn diagram from '97. It's still mostly appropriate, but basically what we're showing here is that there are a lot of different overlapping issues, groups, and different factors that go into different decisions and ultimately into practice guidelines. Clearly there's the evidence. We'll be focusing on systematic reviews. Ideally, the systematic reviews will be able to focus mostly on randomized trials. My guess is, and this is particularly true for the surgical literature, as you probably well know, there are often not many randomized trials, and so we'll clearly be using a broader set of evidence, other study designs and so forth, to develop the evidence. Guidelines, recommendations are rarely black and white, such that everything should be done, a specific thing should be done in everybody, in every setting. I mean, certainly there are recommendations like that, but in most situations, people's values and preferences, cultural factors, different levels of experience in the clinicians, different interests, goals by the patients and their family, and so forth, play a role in what decisions are made to improve the healthcare and quality of life and outcomes in general for different people in different settings.
Yeah, been hesitant to bring in patients in to help us construct the guidelines. I think, though, that many groups have felt the same way constructing guidelines.
Yeah, I think it can be helpful. I think I have a slide talking a little bit about different groups, people who can be brought in.
I think
But
it's
the
hard
patients and
because you
patient
get,
advocacy groups can really give an important
I
perspective.
think it's hard because when you bring in, say, one person to represent all patients, it's only that person's experience that really comes into play into the guideline and not what might be based on a group of patients.
Well, how do you keep that from being the most subjective portion of a contribution to a guideline? I mean, let's face it, most patient advocacy groups revolve around a particular issue related to something negative that had happened, and they bring a certain bias to the table. that there's not a patient advocacy group out there just researching esophageal disorders because it's an interesting topic.
Well, I'd say that it's bringing in a viewpoint. What I was going to say is that probably a patient advocacy group, or maybe several representatives of several patient advocacy groups, is, in my experience, a little bit more useful than having kind of arbitrary, random individuals, because hopefully that they'll have a broader perspective. But you're absolutely right. I mean, everybody comes in to this process with a perspective, and in a sense, actually, you're looking for that bias. You want that alternative perspective. It doesn't mean that the recommendation has to revolve around their thought process and their perspective, but it's important to bring in the ideas that you're all surgeons, you're all looking at this from the clinical perspective, from the surgical perspective. There are lots of different stakeholders out there with an interest in this and with perspectives that are going to differ from yours. Starting probably closest to you, it may be the nursing staff who have a different perspective in the way they care for patients, and they'll be seeing things differently than the surgeons do, and depending on what the guideline is, anesthesiologists may have some important input. Going more broad, and then at the other, it's not really an extreme, but at the other end, again, the patients, families, patient advocates, to get those different perspectives. Other stakeholders that may play a role, may be useful, will be policymakers, hospital administrators, people running surgical units, from an administrative perspective, government policymakers, people from industry, people from insurance companies, payers, and so forth. So I'm just kind of throwing this all out there. I'm not saying that you need to have these people in your group. It may be that you may want to collect some representatives of different types of stakeholders to send the recommendations to and get their feedback for you to incorporate in any revisions that go on. So it's really, the concept is just to broaden the perspectives that are available to you, writing the recommendations. It should not only improve the recommendations, but it may also make them more acceptable to users, because they know, they know that this isn't just, these are what the surgeons are telling us to do, but these are the recommendations with input from a lot of different people. Again, a lot of what I'm going to talk about are kind of the ideals to strive for, or at least what some people think are, and then again, you need to decide what's feasible and appropriate.
It can be hard, and to try and get other people's perspective, because certain groups of doctors sometimes have very different perspectives on treatment of diseases. For instance, reflux disease. We are going to rewrite our reflux guideline, which we're going to promote surgery as a good treatment for reflux disease. A lot of the GI doctors are relatively against surgery and think that other measures are better. It would be nice, I think, to get a GI doctor involved on the guideline, but we're somewhat hesitant to do so. I'm not sure how to do that and come to an amicable agreement over the literature, basically.
Yeah, I'm not sure I have any real
Well, that's a
recommendations.
perfect example because it's a continuum disease. It's not. There's very little that's black and white and gray, right? As we found during the first painful 7 years of
I'm trying to write it.
of that process. So I think, as long as you select an expert who is recognized as having a pretty neutral position, there isn't a one therapy that's right for any one individual. Everyone always has at least two choices. So I think you can find somebody.
Well, I think that's the goal, is not to maybe get a society to help out, but to find somebody who's against surgery to help out.
It's speaking really from the evidence, so whether they feel they're against it or not, shouldn't really matter when the guideline is speaking from the literature, right?
So the problem is you can read the evidence a little bit differently, and you can decide that this one, say the prospective randomized trial of PPI versus surgery, which showed that many people were on PPI afterwards, after their surgery. If you believe that that is the #1 article for reflux disease, then it's going to be hard to sway your opinion to look at the rest of the evidence.
Well, more than, yeah, I mean, that's a good point, but in addition to that is that, I mean, the work group will look at all the evidence, but the evidence is always open to interpretation. There's no getting around that. So, it may be, if the group really, I mean, worst case scenario, a group or an individual has a bias and sticks to that bias, it's very easy to read a lot of the evidence and find flaws and so forth, or to downplay the flaws of other studies. There's always issues about the applicability of studies, whether, or issues about whether that was the appropriate outcome to develop. So.
It's one of the things I was thinking of when you spoke about the rationale for guidelines. And they're all correct, obviously. But the reason we're writing guidelines here has another few rationales, I guess, such as supporting what our members are currently doing, as well as even the choice of the topic of the guideline really reflects the bias of us as an organisation. And for example, if we're writing surgical management of reflux disease, we've already sort of decided that surgical management of reflux disease is a good thing. I think sometimes we don't acknowledge our own biases for that and the reason that we are writing a guideline. And I'm not sure if there's any right answer for that, but we're quite biased in what we do, and we should, I guess, acknowledge our own reasons for writing them.
I mean, I'll just throw this out there. It may be appropriate, it may be reasonable to say that your guidelines on reflux, on the surgical management of reflux, will make the assumption that the decision has been made to do the surgery, and here are your once somebody is going to undergo surgery, here are your recommendations about maybe which surgery to do, how to do it, I'm just thinking about some of the kidney guidelines. They did a guidelines on care of the transplant patient, kidney transplant. And they made a decision early on, where this recommendation is not about deciding whether somebody would do better with a kidney transplant or remaining on dialysis, and which type of dialysis. This is for patients who are undergoing transplant. And that keeps it focused. It also, kept it kind of, for them it wasn't an issue about bias and such. But if you want, one way to avoid the controversy about who should get surgery is just not to a recommendation. But then again, that may not really fit your needs.
Well, reflux, I guess in terms of surgery for reflux, we do decide who is a surgical candidate.
Yeah.
I don't know that we have to put in the other view necessarily if we're just deciding this is who would make a reasonable surgical candidate. We'll just list the number of things that you have to do to show that somebody is a surgical candidate. That's different than saying we're going to look at all the options of care and here are the other options.
On the other hand, though, if let's say you have a GI group involved in a guideline that talks about indication cases for surgery, right? And you do come to a common implications that might actually increase the likelihood of GI docs offering surgery because their group participated in the drafting of that, rather than standing alone and saying, oh, this should happen, they may say, oh, there are a bunch of surgeons, forget it, right? So you increase the buy-in from the people who referred those patients to you. So there may be more benefits actually to go that route than more negatives.
A good example would be like type 2 diabetes and bariatrics. Till we came out with our guidelines and a few other groups, surgery for control of type 2 diabetes wasn't even in the playing field, wasn't on the horizon, and just by coming up with some of these recommendations, it's part of the algorithm of care.
What I get out of this whole discussion, and this is, you know, a new thought for me, is before you set out to write guidelines, you should really define how inclusive they are going to be. Because, and that should be, I think, a decision right before you even start, because, you know, on Tuesday we had this discussion, oh, should we get them involved with this? But the problem is, I mean, it never stops, you know. Like it was saying, you know, you could get insurance companies involved and patient groups and so forth. And yes, that would be a huge inclusive guideline on reflux, on how to treat reflux in the world, you know. But you really have to, in the beginning, say, okay, these are the groups that should participate in this guideline, and I think just define it right up front. Otherwise, it becomes an endless story.
Yeah,
or
defining the scope is a critical
you know,
phase.
right from the beginning.
Certainly what we have done on some guidelines is try to define the scope and then find if the scope is too large. So for instance, we've been trying to write privileging guidelines for endoscopy. We had hoped to get GI groups involved, but after working on that for several years, we're not able to come to a consensus with the GI groups, and therefore have had to go out on our own and do it, and we'll see if they'll retrospectively sign off on it or not.
But I think you also in the process have to recognize, you know, what's a data-driven concern and what's just simply a political economic concern. And you have to be willing to call a spade and just move on with the project. That's my view. I mean, perhaps we'll hear some suggestions about how to deal with that, but you know, just because it's another professional society doesn't mean that it's a conflict-free opinion.
Just to add one thing on the evidence side, I think that we don't often acknowledge, or as often as we should, the heterogeneity of what we do. And what I mean by that is when you're looking for evidence to support conclusions in surgery, the literature's rife with examples, and for instance, from the vascular surgery literature, when you think about carotid endarterectomies, what you do really depends on how good you are and how often you do it. Esophagectomy is the same way. And you know, many times what we're doing is we're essentially making recommendations based probably off what's done by the very best of the best people that do it all the time. You know, hundreds or thousands of cases a year, or thousands of cases in a lifetime. And I don't think we spend a lot of time talking about, well, one of the reasons it's so hard to draw conclusions about what to do for someone in a problem that's surgically treatable is that we don't know if we're as good as the people that wrote the papers, and we don't know if the people that are reading our recommendations are as good as we are. You know what I'm saying? So I'm always, and I tell this to medical students all the time. You have to. It's not like giving beta blockers for hypertension, where the dose response is can be very carefully managed. So that's one of the things through years as I've been doing this, that has bothered me a little bit, is that, you know, I vividly remember as a fellow going to see a couple of guys, as a resident, interviewing for fellowship. I watched them doing this in fundoplication. I was like, I'm not coming here. Those guys don't know what they're doing. And, you know, these were people that were teaching chief residents that were in fellowship to go out and to do minimally invasive surgery. So I think that's something that we need to do a better job of acknowledging and thinking about as people write guidelines and write that.
So I think what Wayne brings up is that the surgical literature, one of the things that it doesn't address very well is what exact technique was used and who did it, but this has a significant impact on the outcome of whatever they're looking at. And that's a little harder, but let's keep going because there's a lot more good information.
Yeah, I mean, I fully acknowledge and I'll encourage the work group to acknowledge, I'm sure frequently, that the surgical literature can be very problematic in many ways, and that's definitely one of the issues, even in the randomized trials. Obviously, there are differences in techniques, and so interpreting the surgical literature is more challenging than other types of literature.
Set by an interest. Just teasing.
Well, there's empirical. I can back that up empirically. But
I think to be fair, any people that are doing individual and complex interventions, you could say the same thing about physiotherapy. You could say the same thing about psychotherapy.
Oh, it's even worse for behavioral.
So there's many other people are dealing with the same thing.
The other end of the spectrum, if you look at, say, prospective randomized trials using low life rate heparin for prevention of DVT and PE, those are all paid for by the companies, even though they're considered very, very good trials, they still are biased in their own way.
Okay, I just wanted to make the last point on this slide here that where things have shifted over, certainly over the last 20 years, last 5-10 years, is that including patient factors, values, preferences are really now considered to be an important part of the guideline recommendations themselves, and not something that gets added, on top of that. And they may not show up directly in the recommendations, but definitely in the rationale and discussion about them. But there are choices, and those choices there are choices to be made, and those choices have to include patient values. Okay, let me skip through a bunch of this. There are lots that have been over the years, many different suggestions about how to write guidelines. And probably the most, I think still the most recent and the most thorough has been the Institute of Medicine guidelines. I'm not going to go through all of them. Let me highlight some of the more important issues about what they recommend. Transparency. Very important for believability, for usefulness, to get up onto guidelines.gov, the National Guidelines Clearinghouse. Guidelines should include an explicit description of their process and their funding. Conflicts of interest related to the funding. Conflicts of interest should be managed by reporting, exclusion, and divestments. This is an aspirational standard in many ways, and particularly for relatively smaller groups, societies like yours. If the recommendation was being written by an international body, they could probably deal with conflicts. You're almost by definition, all your work group members have a conflict, just by virtue of being surgeons. As long as you're transparent about it, you mitigate them as best as possible.
But that's been a question that's come up multiple times on our committee over the years, is you get some people who truly may be the expert in the field. Does that all of a sudden put a conflict of interest because they've written some plans? So how do you, at the same time you're saying, get the experts to be able to write the guideline, but get rid of the experts because they're, we're always struggling with that a little bit.
That's a great point, and it's an issue they raised, and I might have a slide about it, I don't remember. The experts, by definition, are more conflicted than the other people in the group, so the goal really is to try to get a balance. If there's a clear conflict where somebody's opinion will be looked upon. Well, if somebody has such a conflict that including them in that decision making will look bad, basically. People will make it, find it less believable. Then that's a major issue. But clearly, you need to get the best research, the most experienced researchers in, or the evidence from the most experienced researchers in, or the people who are most skilled, who are most knowledgeable. Those are the people you want to include. So the trick is really to try to achieve balance. Again, it's not something that's always completely feasible. A lot of it, actually, almost all of it is perception, really. Related to this issue about conflicts, the next one, members of the guideline development group, the group should be multidisciplinary and balanced. Again, that's something that, for your society, it may be difficult to achieve. You're not going to get an even balance of surgeons and internists and nurses and patients and so forth.
I think
it shouldn't necessarily be what you want to do. But
right. Remember, as we talked about the other day, we're writing surgical guidelines for surgeons, and the fact that we have a diversity of surgeons, maybe that's the important thing to say. With all over the world, from all different disciplines, and different kinds of practice.
Well, that's what we're going to have to do with the, say, the TAMIS guideline, which is being written by somebody who is using a certain instrument, and the TAMIS guideline is going to be based largely on that instrument use. So we, as people out who don't do that type of surgery, are going to have to look at that before it comes out of our committee and make sure that we agree with the what's been said in that guideline.
Okay, number 4 is review of the literature. I think this is pretty much straightforward. The guidelines should be based on systematic reviews of the literature. But you should recognize from the onset that not every recommendation will be amenable to being based on the literature, because the literature either will be of such poor quality or just lacking altogether, or maybe there are recommendations that are not necessarily related to the evidence specifically. Rating the strength of the evidence and the recommendations. This is, well, at least over the last, let's say, 10 years or so, a relatively new concept. I'll be talking more about some standard approaches to take that I would encourage your society to follow. Not so much because they're better than any other approach, but mostly because they're standard, and which helps in interpretation and also helps kind of in believability that you guys have done a good job and used accepted methods. So each recommendation should be accompanied by the underlying reasoning, the potential, again, benefits and harms, the evidence, the quality of the evidence, the contribution of values, preferences, experience, and so forth. There should be a rating of the level of confidence in the evidence and the strength of the recommendation itself, and differences of opinion regarding recommendations. A couple things. One is the approach that I'll be recommending is the grade system, and I'll come to that. And that in that system, you rate the quality of the studies, you rate the quality, the strength of the body of evidence, and you give a particular strength to the recommendation statements themselves. High strength, you should do something. Weak strength, you suggest to do something.
We have been using the grade so far.
Great. Okay.
The other thing is we've just, I'm hoping we're about to get EndNote for everybody that doesn't already have it. We're about to sign a contract with that. I hope that you agree that EndNote would be a reasonable way to follow keep our literature on track.
Sure, yeah. I don't have any strong opinions about that, but, yeah, I mean, we have an, a ground, so that'll work well.
The issue we're having is we have multiple people working on the guideline from different sites, so do you recommend something where there's a common portal for it that everyone can log into, or?
Yeah, I guess, I don't know who we'll have this discussion with, but my personal preference would be to use Google Drive, but I know there may be some issues with that. Not everybody can use that on their hospital computers. Hospitals in particular prevent downloading the software for it. I think that issue is a problem for essentially every shared internet-based network, cloud-based folder. So I'm not sure. But if you guys have something,
A lot of us have used Dropbox. I don't know how that differs from Google Drive.
Google Drive is it's essentially the same.
Before we get to the discussion, are we going to have a segment where we're going to talk about the how-tos? What's the best way of doing it, so we don't interrupt the flow of the
discussion. That's true. I mean, although I wasn't thinking of even going into this level of detail with the how-tos.
Are we going to do this in the afternoon, maybe, with working groups? Like all the tools that you have. Yeah. That you use.
Yeah, I'll show some of them. I hadn't really thought about it. I mean, we'll need to make a decision now where we share share things. Okay. Number 6, presentation of the recommendations. So I mentioned this before. The guidelines should state precisely the recommended actions. In other words, they should be actionable. When they should be performed, and ideally how they could be measured for evaluation of compliance. I actually haven't seen that very much, but that's a goal to strive for. It's something that actually often gets pushed into decisions-backed performance measures.
So this means implementation, how they're being implemented. Or if people conform with that?
What the IOM is actually recommending is that the recommendation itself, or at least the discussion about the recommendation, should cover how an individual can measure whether this recommendation is being followed.
For themselves.
Actually, that's
so give us an example. Give us an example. Just an example guideline and what it would say.
Well, I've actually never. I don't think I'm not sure I've actually seen this in practice. I think the examples are the clinical performance measures. But yeah, if you have.
It has to be specific enough,
right? Yeah, like it says sternotomy, you need to give antibiotics before the incision, and you can say that comes up with some measure that would say that it was or wasn't done.
And I think it has to be very followable, not like appropriate antibiotics should be given in the right case. That would not be one that you can measure, but before incision, 30 minutes in this type of procedure, you need to give one dose of this type of antibiotic.
And I actually think for surgical guidelines, there's going to be relatively few of those that are so very easily stated.
And those will be the strongest recommendations based on the best evidence, where you can actually be that detailed.
In the past, we've come up with guidelines that use the word may or should or must. Is that sort of current practice, or is it more give the guideline with the recommended level of evidence? Or
the suggestion I'll give to you is to follow the standard of either saying something should be done, and that's a strong guideline, usually based on good evidence, or you suggest that something be done. It's a weaker recommendation, usually based on weaker evidence. It may be based on very good evidence, but there may be a wide variety of values, preferences. that don't allow you to make a specific strong recommendation. And then there are, again, number 7, this is from the IOM standards. They are suggesting that guidelines should be reviewed by the full spectrum of relevant stakeholders. The general public should have an opportunity to review the guidelines before they are final. There are obviously practical considerations about how much time and effort you can put into this.
We've been fortunate that we've been able to put or recently, once we decided to do this, and we could put that up on our website and have people sign in and say something, so.
Yeah, at a minimum, you want to advertise it to your whole society and give everybody in SAGES an opportunity to comment, and then probably more broadly also. And then updates. Actually, this is something that National Guideline Clearinghouse looks for when they kind of read through a guideline to summarize it. The guideline should state the date of publication and the evidence review. That's pretty standard. And it should state when you believe the recommendation needs to be updated, kind of give a time frame. So ideally, you would say this recommendation. Let's say it comes out in 2016. You'd say that this guideline, will need to be updated within 5 years by 2021.
So what happens if in that time frame you look at the guideline and you decide it's good enough, you don't have to change it? What do you have to do with that? Just change the update thing that was relooked at that point?
Yeah, I mean, you would put up a description that a review process was done. A basic search for new evidence was found. Nothing was found that would change the recommendations, and the guideline is still valid. That's something that, again, the National Guideline Clearinghouse would be looking for, and they would count as an update.
I suppose you might, under those circumstances, add whatever's good evidence to the guideline. I mean, to stronger substantiate a point that you've made. You might not change your recommendation, but you could say it's strengthened by X evidence that's happened since.
Yeah, definitely. I mean, if once you go through even the basic process of looking for the most important evidence or the most or the evidence that's easiest to find for an update, there are always going to be some variations, some changes, maybe a strengthening of the recommendation or a strengthening of the evidence base.
And Dr. Schweigensberg just walked in, who is a past president of the society.
Hey, I'm sitting in the suburban meetings to go to, but I wanted to come here and chat to say for me.
Thank you for coming.
Okay, so I'm going to go through some of the process steps and who's involved. There's probably nothing too brilliant on this slide. I assume this is all covered. There needs to be a leader, somebody who can build consensus, content experts from the range of specialties and perspectives that are required for the particular topic, methods experts, and that's what you've brought our group in for, to help you out with, for guidance on the systematic review of the guideline development process. Administrative support, obviously have that. And then ideally, again, we've talked about this, consumers and patient representatives, if feasible. Okay, let me jump through a bunch of these. This is
that
just
last slide was actually an important point of that.
Okay.
Because I think we sometimes, some of our guidelines are becoming very long and lengthy, and I think trying to figure out how we do concise summaries and explicit rules is an important component we need to better. And part of it that we've done where we've actually summarized in a thing at the end of the guideline and have a standard format for that.
So I think Ethan will address this, but one of the issues is because we've always pretty much done a systematic review and a guideline in the same document, and and I think Ethan's one would be, we need a systematic review separate, and then a guideline document separate, and that's how you keep it short, am I correct?
Well, it depends on how it's going to be produced. I mean, I'll give you kind of the two opposite ends. When, again, the work that we've done with the kidney development groups, their guidelines are full journal volumes. They're 100 to 300 pages long. They include everything. I mean, that's with appendixes and such. You know, there's a whole methods chapter, but there's also, you know, each recommendation, a summary of why the recommendation is being made, and then a long description about the evidence that supports it, complete with all the tables and so forth. That's, I think, at one extreme. There aren't many groups that do that. What's more common, and what we've also done, is, as you're suggesting, you know, these come out as journal articles, so they have to be short. So the way to deal with it is to have one, or maybe 2 or 3 manuscripts about a systematic, that are specific to the systematic review, this particular comparison, this particular question. And then that's accompanied by a separate article that goes through the recommendations. But then, you know, even within the short articles, if it's a very focused topic, and you end up with just 2 or 3 recommendations that the evidence support, you know, it may be feasible to condense it all into one article.
If I could add, let's not forget where we came from. So that's what we used to do. We used to publish a separate review article and the guideline, and the pagination issue in the journal was ridiculous. You know, we have a certain number of pages each month that are reserved for society business, and that's where we publish. You know, we don't have room in the journal for duplication of the same or very similar topics, and that's how we evolved into combining them. So some of that would have to be discussed with the editorial staff if you wanted to.
So representing the editors, the issue is all about, at the moment, about impact factor. And so if you have the right kind of material, 2 articles that get cited on a single topic is actually good for the journal's impact factor. And guidelines and systematic reviews and things like that are a very high impact factor. That's why case reports don't go into a journal anymore. There's no impact factor. So depending on the topic, I think, you know, you're exactly right. You know, if it's too short, you can't have a 1-page article. But there is nothing wrong with publishing 2 articles from a strategic point of view to meet the paginations, or 1 month after the other, or one, you know, that's okay if it's a really important topic, because it'll be rewarded in impact factor.
Yeah, I was going to say that, you know, systematic reviews and guidelines that people like and find believable have some of the highest impact factor effects. Lots of different groups have used different systems. Just stop there. Okay, so I think I've mentioned some of these things. Again, the recommendations themselves should be specific and focused and discuss alternative management strategies and provide guidance about how to choose among those alternative strategies. This is an issue that gets graded in terms of the strength of the recommendation, the quality of the body of the evidence. As I said that backwards for this slide. Just some definitions here. So, and I'll use these terms a lot today and going forward. Quality of the body of the evidence is the extent to which one's confidence in the estimate of the effect is adequate to support a decision. You could probably tell by the way I read that, but the most important word in there, I believe, is confidence. Because the whole system for evaluating the quality of a study, evaluating the quality of the body of the evidence, even if we set up a highly structured system, it still ends up being subjective. There's really no getting around that. It's people's decisions about what, whether it's good quality or bad quality. And so really the important thing is how confident are you about the results of the study, the applicability of it, any potential biases and so forth, and then all translated up to the level of the body of evidence, all the studies together. The strength of the recommendation is the extent to which we can be confident that following a recommendation will do more good than harm. So, this should be based on the evidence, but again, it may be somewhat, separate from it. There may be some surgical techniques that you recommend strongly, not because there have been studies showing that technique is better and safer and so forth, but because through your experience and so forth, you believe that to be the case, and it may be self-evident. Again, confident. How confident are you that following the recommendation is better than not following it? This is the basic grade scheme. I guess you guys have been using this, and it's what I've been talking about. 2 levels: strong, basically do it; weak is probably do it. For a strong recommendation, there are always exceptions, but basically everybody should do this. The weak, values, preferences come into play much more. The quality of the evidence. This is the quality of the body of evidence, all the studies brought together. And this is the grade system: high, moderate, low, very low. Our group has tended to kind of drift away from this very low level, and the Agency for Healthcare Research and Quality, which funds the evidence-based practice centers, which do systematic reviews on broad topics, we at Brown are one of these centers, has also kind of shied away from this very low. Distinguishing between low and very low is difficult. Even distinguishing between high, moderate, low can be very subjective, and then once you're down at the level of low, it's lousy evidence. So, what's lousy versus very lousy evidence?
When we were writing the guidelines, we frequently found ourselves coming up with moderate to low quality of evidence and a weak recommendation. Is there any benefit in actually including a guideline that has weak recommendation and low level of evidence, or should we just ignore it?
There will be some topics, recommendations you consider that you decide, the evidence is so poor, we're just flipping a coin here. And you may not want to make a recommendation. You should probably still discuss that issue. Because the evidence was so poor, we don't know which is better. We're unable to make a recommendation. So that's perfectly reasonable.
As he said here, weak is probably do it.
Yeah.
So I guess we have to decide, is our recommendation so weak that we really feel it's like flipping a coin, or is our recommendation weak, but by that we mean probably do it?
So is there any place left for in situations like that where there are things that are done that are fairly common practice but not well studied and perhaps supported by expert opinion of the people who do it all the time? Would you then say, we don't have evidence, but we do know that this is being done, and there's no evidence to say that it's unsafe or that it harms patients?
Well, you can look at the skid benders, which are strong recommendations based on possibly, in some of them, very low levels of evidence.
Can I make the argument just as a question? Just looking at how you define weak as Bill said, it probably is a misnomer, right? Because if it's probably do it, it's not really weak recommendation. It's maybe less strong recommendation. Am I right? I'm just asking.
No. I mean, I've been part of this.
Weak would mean you should probably not do it.
Yeah,
I don't know,
yeah,
the way you read it is...
I've been part of this discussion for, I don't know, I feel like since the day I was born. And there's no answer. And a big part of it is American English versus British English versus international English versus translations into other languages. And this really came up with the kidney guidelines, which were international. And I may have the languages wrong, but if you translate these words into, yeah, definitely in Japanese, it's impossible because weak means it's bad. You know, you're making a bad recommendation. And that was an issue for some of the European languages also. I don't remember which. With German was an issue. So I'd say don't get hung up on the actual word. I just kind of use it as a concept. The recommendation itself is not going to say strong or weak. You can decide whether you want to include the number 1 or 2 in it. It may just be should and suggest, and that's kind of the end of it.
So we typically, at the end of each of our recommendations, we include the level and weak or strong. So your suggestion is do not include
No. I will suggest doing that also.
But then if
it's not required.
If it reads weak, I think everybody's taste.
No. But I wouldn't say weak. I think the numbers and letters are safer for that.
But how do you deal with when you get to something that you shouldn't do? So let's take the classic renal dopamine, which was based on one animal paper that everybody did it. If you're old enough to remember it, and the recommendation would be you should not.
Yeah. This should be read as a strong recommendation would be do not stab your patient.
Do or do not.
When it's something you don't want to do, you switch your recommendation to we don't recommend dopamine, and then it would be weak. Right. Instead of we do recommend dopamine.
It's strong recommendation.
Okay, but you get my point. It's changing the words of the recommendation.
Yeah,
if you feel it's
probably do it.
Yeah. But how do these, getting back to his question, like if here's the universe of patients, the guidelines and the data may sort of take this big circle and there's all these patients that are sort of sitting out of, how do you deal with the fact that there's whole collections of patients that have individual characteristics that don't fit into, gallbladder should be done laparoscopically, well, what if you've had 11 previous operations? What do you do with patients that fit outside of the universe?
Well, the whole guideline need to have the caveat that these are guidelines. They're not commandments. That they are suggestions for the preponderance of patients. They will not apply to every patient in every situation.
That's not how they're used.
But we do have a very good disclaimer we spend a lot of time on at the very beginning of each of the guidelines that specifically addresses that. And so you're right, because it still ends up in court, it still ends up all these places, but we have that disclaimer on the front of every guideline.
Yeah, I agree.
Yeah, there is a limit to how much you can, what you can do to prevent litigation and so forth.
So I think I learned something just from this slide. We're going to switch the stating strong or weak to 1 and 2. That sounds better.
Yeah. Somewhere even the paper you're going to have to say what 1 and 2 is.
Yeah. Well,
it's fine.
It's subjective. That's what I struggle with.
I agree. Should and suggest are very good words.
Yeah. Let me jump here. This is some of the interpretation about what this 1 versus 2
He's ready
means.
for us.
I had the slides out of order apparently, but so
this is the recommendation or level 1 versus
these are the recommendations. Strong versus weak, do it versus probably do it. And something like this can be in a little table that you have somewhere. Patient preference. Almost all make the same choice. It's not 100%, but it's almost all. But for a weaker suggestion, let me call it a suggestion, choice may vary appreciably. The implication for the clinician for a strong recommendation, in most settings, you would just inform the patient, this is what we will do, or this is what I suggest doing. But for the level 2 recommendations, they require more discussion about what the patient's values are, or maybe a discussion with clinicians and so forth to help decide what's most appropriate for this patient. Policymakers, I mean, this will come up, be an important issue. At least they should only be making standards, performance measures based on your strong recommendations. I guess that goes into the quality care measures also. None of this is black or white. I mean, I think that's something you keep in mind that you know, even though you have guidelines, they are just guidelines. They're not something that is going to be performed by every clinician in every setting and for every patient. Okay, what increases your confidence? The following recommendation will do more good than harm. What makes it a stronger recommendation? What makes it more likely that you will say you should do this rather than you suggest doing it? High quality evidence supports that. That doesn't mean you need high quality evidence to make a strong recommendation, but the higher the quality of evidence, probably the stronger the recommendation. The balance between benefits and harms clearly favors the benefits. That's values and preferences. Patients have similar values about possible benefits and harms, so I'll come back to this in a minute. And cost. If it's an inexpensive intervention versus an expensive one, and otherwise it's a flip of the coin, obviously, you could make sense to have a stronger recommendation about the inexpensive one. That actually doesn't come up too much in a lot of these guidelines. With the, let's see, the values and preferences, patients have similar values about possible benefits and harms. When I talk about systematic review, I'll be talking about ranking the different outcomes, and this is an important issue for that. I'll be talking about critical outcomes and patient-centered outcomes, and surrogate and intermediate outcomes at the opposite end of the spectrum. And the more critical the outcome, probably the more similarity there will be about values of benefits and harms. So I think you can assume that everybody values death pretty much equivalently. Everybody values chronic pain similarly, things like that. Whether people value length of stay, whether people value, how they value, short-term nausea, how they value, whether their GERD is improved versus fully healed. Those things are going to differ among different patients. So the values and preferences may be very outcome-driven. So if there's good evidence about critical outcomes, death, full healing, full cure, then you can probably make stronger recommendations. If your evidence-based is more about surrogate outcomes or squishier outcomes or outcomes that people have different preferences about how important they are, you'll probably make a weaker recommendation. Okay, I think this is all saying the same thing over and again. Okay, I'll write through this.
So quick question, so for strengthen, are we going to agree with some sort of wording to use for the ones and twos at some point offline?
It may depend though a little bit on what type of recommendation it is, but I think in general the should versus suggest will probably cover most of what we do.
So the way I see you wording is when you say recommend, that is strong, when you say suggest, that is weak. right?
Yeah, that's the system that that we will recommend to you. Yeah, so, and I'll say that we came to that, I mean, Grade helped us to do that, but we came to that after many years of changing wording, changing systems. I think you said something about pediatric dialysis, I don't know if you meant, don't know if you meant kidney dialysis, but if you look back at the old kidney guidelines, it was really difficult for users because every guideline would come out, the wording would be different, the system would be different. It was a mess. But we had so many different competing groups who would come to the fore for different guidelines. So this is why I'm recommending Grade, because it's a standard system. Other people are using it.
One more question, because it's all in the part of the words. In our definitions, should is strong, typically aligns with a strong recommendation, right? Now, but if we were to use the recommend surgeons should do this, makes sense. We suggest surgeons should do this, is that now a conflict there? When you say suggest and should, you should avoid using the should?
You can drop the should in the second sentence. We suggest that so-and-so, such and such be used.
So, but you would recommend against using a word like should when you say suggest?
Yeah. Keep it clean.
I would think, I know it's, like you said, it's the power of the words. If I read a guideline that SAGES suggested doing something, I think that's a strong recommendation.
Well, that's why I said less strong, right? Probably should do it.
Well,
so.
Well, what can be very helpful is in the article, in the manuscript that has the recommendations, that there be a table that explains. It'll be a table that was it. Oh, I don't remember where it is or if I've shown it. But there could be a table that says, one should explains what it does, explains what the implications are. Two suggests. So it's right there. I mean, you'll never.
But what our members are going to do, I know sure, is they're going to go to the list of the guidelines at the end of the paper, then go to ignore the many hours of work we've put in for everything above it, and it's going to say missing fundoplication is suggested as the right fundoplication by SAGES or something, and that's a weak recommendation because we've only suggested it. And they're going to say, look, they told me not to do a partial fundoplication.
Yeah, I don't think we should get bogged down with the exact words. I think that we're going to make explanations in our drafts about how we came to such a recommendation, right? We could sit here all day talking about what the means.
I think we have to be wary that people will only read the recommendation, and we have to get.
Well, I think that's.
Well, they might.
It's just like way
because many people don't read any of it. So, but if we can get them to read the recommendation.
Yeah, if they read the recommendation, that'll be pretty good.
We'll have to have some long discussions about this, and particularly when the recommendations actually get written.
Yeah, sure.
This will be discussed.
As long as we use standard language, I guess. Right.
Yeah, and this. I mean, if you look at a list of recommendations, and some of them are saying you should do this, and some of them are saying we suggest you do this. I think it's probably clearer in that context that there is a difference. But yeah, the other thing, people will misinterpret no matter what you say.
And we do have a single document of the definition, so we put a lot of time in defining each of those things. And that actually would be an important document for anybody writing guidelines. And we ought to review it at some point.
I think what we might need to do is have you review it, make sure there's no ambiguity based on
definitely.
If you need to make any modifications, we definitely can.
Okay, this is kind of a variation of the grade evidence profile. Throw some jargon at you. This is called an evidence profile. I don't know why I don't have it up on the slide, but so you say you've been using the grade system. Have you been creating explicitly these tables?
We need this kind of sheet
So,
when we're going over the articles.
yeah, and the work group will definitely have it. So.
I think this is one of the key things that we need from you is how to better do this
Yeah.
process here.
Yeah. And this
So
is
can you
our bread.
describe
This
this?
is our bread and butter. Yep. So, and I have an example on the next slide.
And
But
let's say you, an individual member has 20 papers to review.
Mhm.
How do they put that in here?
Okay. So, let me start by saying that each of these rows is a separate outcome. So the O1 and O2, each row is a separate outcome.
Death, nausea.
I'll get you copies of all these slides.
Outcome means the question.
No, the outcome. Death.
Like hernia recurrence or
Hernia recurrence.
recurrence of
Yeah.
GERD or rate of people still on PPIs.
It's interesting because most of our outcomes have to do with harms in
Yeah.
surgery.
Well, I was gonna say, yeah, quality of life,
Yeah,
and then, yeah,
Positive and
a
negative.
lot of them have, a lot of harms.
yeah.
Very worried about harms.
Good. That's a great point.
I'm
So
sorry.
how do you define harm
Well-
versus outcome?
Well, that's what I was just gonna say. This, the grade system. This table was created by research, mostly medical doctors, interns, and such. So, and most of this was created in the context of, ideally we'll have randomized trials. So therefore, most of the thinking was about drugs. So a lot, so that's why the harms, I think, are kind of separated out.
Does that mean that there's room for a framework in interventional specialties because the issues, there might be specific features of harm that we do as interventionalists that are different, not that it would be radically different, but that there might be some additions or different ways of thinking about intervention different than drug treatment?
Yeah, this is just a general structure that should be modified to fit your needs. And the first modification, this table is based off of the grade. I'm kind of using it. I didn't modify this slide for this talk. But I fully agree. I'm not sure it will make sense to say, here are our outcomes, and here's one row for all the harms. I think the harms will be a series of rows, because you have, intraoperative issues, you have postoperative issues, you have long-term issues, and so forth. And so I would say just consider all the harms to also be other kinds of outcomes.
And that's the thing, you might talk about desired outcomes and undesired outcomes.
Yeah.
And what are the probabilities of both of those.
Yeah.
Yeah, this chart is to be used in the creation of our recommendation, but not necessarily published in the guideline.
Or are they included in the actual?
No, this could be in an appendix, or in some situations actually in the paper itself.
So it has to be published. As
Yeah.
well. Yeah. That's good practice.
Yeah.
Publish.
The goal of this is to help consolidate the work group's thinking about the evidence, but it also helps with the transparency.
And if I may, just for clarification, because traditionally what we've done is we have created tables, but typically tables are organized by paper. Like when you have all one or two papers, such and such, paper such and such, and this is the outcomes. Kind of the outcomes are in the columns, right? And we have summaries in the end.
Right.
But this is a different way of doing it. Yeah. We should not be doing that.
Well, it's not a different way of doing it. It's an additional way of doing it. So I started with the recommendation. I'm moving to evaluation of the body of the evidence, and then eventually move down to the specific studies. So I'll complete the complete set of tables and so forth, and documents will have the manuscript, the list of recommendations, the description of the body of evidence, which is what this table is, the evidence profile, and then what we call the summary tables, which are what you're talking about, which are the study level details. And you can make some decisions about how much you want to include in that. If you look at a full evidence report, comparative effectiveness review from AHRQ, you'll see all of those are included. You'll never print out the appendixes. They're very complete. Whether you need to do that for the recommendations, I think we can discuss
Now,
that.
there are a number of programs that allow us to do this on.
Yeah, I would actually recommend just doing it by hand. I think those programs are, personally, I find them impossible.
So do you have definitions of what some of those things are?
Yes, yes, oh, definitely, yeah. Okay, so each of the rows is an outcome, and for each outcome, there's a description of how many studies evaluate that outcome, how many people were in the studies, what the methodological quality, and later today or with the work group or in future discussions, I'll talk more about this, but what the methodological quality of the studies were that evaluated each outcome.
Yeah, but you give a range, like 1 to 3, or average, or the best, the lowest, or what?
The way that
There's going to be different studies, probably.
Yeah, the way, I'm just trying to see if the example.
Each row represents a paper.
No, an outcome.
It's the total outcome and body
So
of
we probably
evidence.
need like 20 for each one.
Okay, well, let me hear, okay, I don't know, is that readable for you guys at all? Okay, so here's an example. This is from the kidney guidelines a few years ago. Treatment of membranous nephropathy. One thing to bear in mind, this table is for a very specific question. Alkylating agents and steroids versus control. It's not for all treatments compared to any other treatment. So depending on how we structure these, there could be a lot of these tables for each specific comparison, each specific question. I mean, there's inevitably going to be some lumping together, but this is covering one specific topic. So again, list of the outcomes. Each row, first row is mortality, the most critical outcome. Next row is end-stage renal disease, an equally critical outcome. This is a situation where there are people who have the preference that they would rather die than continue on dialysis. So again, preferences do come into play, even in critical outcomes. Remission of disease, relapse of disease, proteinuria, kidney function, a different way of measuring proteinuria that's less meaningful as a continuous, and kidney function also continuous. And then adverse events, which were all lumped together in this setting. I mentioned it briefly before this table was created. All the outcomes were given a level of importance. This is irrespective of the evidence. This is the work group's consensus about how important each outcome is. The system that KDIGO was using was critical importance, high importance, moderate importance. If there's low importance, it's not included in the table. If it's of low importance, it's of low importance. You don't need to consider it. Again, the number of studies, we separated out the study designs because we were including randomized trials and also systematic reviews, and we decided to keep those separate for a variety of reasons. But it may be randomized trials, observational studies, and the number of people. Methodological quality. Okay, there are a couple different ways to do this. Here, what was decided, and this is more closely following the grade suggestion, the grade approach, is to give an overall summary. Are there some limitations to the quality? Are there no limitations to the quality? Those are the two, or I think there's also I forget the terminology, but I don't know, lots of limitations, many limitations, which would be -2. And another example, which I think I'll show you later, is we could alternatively say that there were, so each of the studies gets rated as good, fair, poor, A, B, C. So we would say that there were 2 A studies, 1 B study, 1 C study, and then give an overall kind of -1 for them. So there are different ways of approaching that. The next column, and this is something that we will discuss more with the work group specifically, these other items here. Is there consistency across the studies? If the studies are consistent with each other, you're more confident that what they're finding is actually true. And so there won't, there's either no important considerations regarding consistency.
You mean consistency of outcome?
Consistency of findings. Yeah. Okay, this doesn't have an example of no inconsistency. I mean, important inconsistencies. But that would be the option. Clearly, when there's only one trial, you can't evaluate it. Not applicable. This is a concept that I'm not really very happy with, but we included, again, to follow the grade system and so forth. It's the directness of the evidence. This can be interpreted in a lot of different ways. It's whether these 2 interventions were directly compared to each other, or whether you're getting them from, you have a number of studies on these interventions, and let's say it was alkylating agents versus steroids. So if you had a number of studies that showed the value of alkylating agents alone, and you have a different set of studies showing the value of alkylating agents, steroids alone, but you're interested in the comparison, then that would be indirect evidence. There's methodological debate about this that I'm not going to go into now. Another issue is kind of the applicability of the studies. If the people involved, if the patients were atypical, then the evidence from those are not going to be directly relevant to the broader population, maybe.
Is this where you would also flag if it was an unintended, like a subgroup showed this? The study was designed for a larger group, but when they pulled out a subgroup, it showed this. But the study wasn't designed for that subgroup. Is that where you would flag that?
I don't have a good answer off the top of my head for that, but that's something to consider. It might be, we might just lump it under other considerations.
Okay.
Other issues are, so I work with gynecologic surgeons. A lot of their outcomes are like quality of life related to sexual function and so forth. The scores, the questionnaires that are used in studies regarding sexual function are all over the place, and a lot of them are lousy. They ask not very insightful questions, but we have evidence about them. So it was decided that that was an issue related to directness, because the outcome itself is not directly and cleanly related to the outcome. The way it was measured is inadequate to describe whether the outcome that we're interested in was different. Then there are other considerations. If you have one study, it's very sparse. If you have a small study, few small studies, they may be very imprecise, give you wide confidence intervals. There are other issues. If there's this is not rarely relevant with surgical literature, but if there's a dose response, if higher doses or higher exposures lead to stronger effects, that makes it more believable. So you could actually increase the quality of the evidence. So there are a lot of details in here. I mean, this is, and so there'll be, in-depth discussions with the work group, and then when we actually have the evidence, more discussions with the work group. All of this gets summarized into an overall quality of the evidence as low, moderate, or high. And actually, this is where the very low can fall into place also. But again, the distinction between low and very low is difficult. With the grade system, if you read it literally, it's kind of simple math. If you talk to them, the people who developed the system, they would argue that it's not simple math. So somewhere in between those. But you'll notice that they're negative ones. So you start at high, there's some methodological issues, so you drop down to moderate. There's some other, here there's imprecision about the mortality.
So
a
the
few events,
minus
so you
one
drop
means
down to
you're
low.
going down a level
Down a
from
level.
high to moderate to low.
Yeah. And, we don't need to include these numbers. They can be confusing, they can be sometimes misleading.
But
they also show the process.
What if you have 4 minuses? You go
You
below
only
very low.
you go down to low. Yeah, that's as low as you go. So, yeah, no, that's very common.
No.
I mean, you start with retrospective observational studies.
So
They were
let me ask
badly
this
done.
question. Can the difference in the treatment effect have an influence on how you decide? And the example that I'll give you is weight loss with obesity surgery. I mean, the difference in effect between medical therapy and surgical therapy is enormous, even though you may not be able to say that the evidence is, I mean, there's some randomized control trials, treatment of diabetes, medical versus surgical in severely overweight people, but it's not going to be, you're going to be able to find imperfections in the methodologies of the studies and imperfections in the way outcomes are reported across studies that are going to make the quality of the evidence less, but the treatment effect is enormous. Do you see what I'm saying? So does that change?
Well,
That's what you can upgrade.
that's kind of equivalent, I would say, to the dose effect.
Okay.
Actually, another consideration was, I'm trying to remember the phrasing. I think it's the magnitude of the effect.
And that gives you a plus.
And that gives you a plus. That pushes you up. Yeah,
Where
and,
would the plus be on the table again? Direct, no, consistency?
It could be. It would end up being the only pluses end up being under the other considerations. And there would be some description. There are footnotes to this table explaining why things happen.
So essentially, if you think about it carefully and you've got a really good reason, you can put just about anything in the other considerations as long as you're transparent and you.
Yeah, exactly. Definitely. I mean, the other considerations that grade discusses are, are a starting point. But all kinds of things could go in there, certainly. I mean, with the bariatric surgery, you may not, even though you may be relying on observational studies, but qualitative description of the effect. Sometimes you could put in quantitative data here, odds ratio or something. All of this gets summarized down to the bottom here. So what's the quality of the overall evidence? These critical outcomes are weighted more heavily than the high, than the moderate. I know the critical outcomes are low and the high outcomes are moderate and low, and they decided the overall quality was moderate. I don't remember the rationale, but I believe them that it makes sense.
But it's so subjective.
It's subjective. And
like the whole table is so subjective. You can turn it the way you want it to.
It's so subjective, but it's less subjective than a completely non-transparent table that ends up just being, a text that summarizes what you want to summarize without anything backing it up. I mean, it may be subjective, but it's transparent. So a reader can come in, and if they really are interested, they can look at this and say, I come to a different conclusion. This helps me decide whether I want to follow this recommendation or not.
Otherwise, you're hiding those biases. Essentially, you're exposing your biases.
Yeah, the whole process is subjective. I mean, I said this before. Rating the quality of an individual study is highly subjective. Even things like deciding, whether they, like, trying to decide which example to use. So it's a randomized trial. I don't want to throw jargon at you that. So they say they did an intention to treat analysis where they included, theoretically they included everybody who was in the study in the analysis, even if they dropped out. But there were dropouts, and those dropouts were not included. It's a decision as to whether you think that's an intention to treat analysis or not. Do you deem them for not being intention to treat? They said they were intention to treat. There were only 1 or 2 dropouts. It's not black and white. There's always some level of subjectivity. So this helps to bring out the transparency. It's not making every step transparent. That's kind of overwhelming and impossible. Okay, and then there's the balance of potential benefits and harm. I didn't notice before that this is an overly, I think something got chopped out. There should be a description in here of kind of, these are the benefits and they outweigh, these are the harms. So building on this, building off of that table, they wrote a recommendation. We recommend. So their approach was to say, and maybe we'll end up suggesting to do this also. Instead of the should and suggest, it's we recommend or we suggest. But we recommend that initial therapy consists of they have a table describing what the initial therapy is. Notice it's described fully as, a 6-month course. What's the duration? How is it given? Again, the details of it. Who is, this is one of many recommendations in a section, so it's a little clearer from that. Whoops. But this is the initial therapy, so this is kind of covering who specifically is being treated. It's a strong recommendation. They said here the overall quality of evidence was moderate. That translates into B.
So how do they get to strong recommendation in this setting? Because the really important outcome variables were not well researched, were not well supported, right? Low.
I think that gets the question is, can you have low level of evidence and can you make a strong recommendation?
Yeah, that's kind of, I think you can.
I mean, we've done that, and that's why I wonder how.
You have to write your text about why you've come to that.
That's the question, is a low level of evidence and the recommendation. Sometimes does a low level of evidence dictate that you can only have, and if not, then what makes it so you can change that?
Well, you would have to look at, say, I'm sure it's your confidence in it, but if you look at, say, baby aspirin for heart attack, initially it was a very strong recommendation to do it, but it was based on, if you have a heart attack, it's a really bad thing.
We would take it back to that comment you had on your other slide, that the ability to do good, it came down to whether or not it had the, what was your slide?
Benefits clearly outweigh.
Yeah, benefits clearly outweigh the harms.
Yeah.
So XLAP for free air after blunt trauma. I mean, there's no real good randomized controlled trials for that.
Right.
But I mean, everybody in this room would agree that that's a strong recommendation kind of thing.
Right. That's my point.
So there were discussions about what are the alternatives that are available for treatment. How the alternatives that are available have much worse adverse events, and are more and are considerably more expensive. There was, decent evidence that it had an important effect on preventing remission and preventing, or continuing remission, keeping remission in place and preventing relapse. And that it's unlikely that in the near, possibly even distant future, we're going to have good evidence regarding these outcomes, because they're relatively rare events. And so given the alternatives, given the cost issues, given the alternatives in terms of what the side effects are, it was determined to be a stronger recommendation.
You know, you mentioned cost issues, but you often don't see that addressed in many of these evidence-based reviews.
Yeah.
And I'm troubled by that because we're increasingly being asked to consider value. The payers look at this, they look at these guidelines, they don't have the intellectual firepower when you're on the phone with them. They go, well, the guideline says this, but cost is coming into the equation more and more and more. So my question for you is twofold. How is cost starting to get wrapped up into this? So for instance, let's just pretend that you thought that robotic cholecystectomy was a great idea, and your evidence is you can do the operation, you can do it safely, and based on the strength of the recommendation, it is a safe and effective method of taking out your gallbladder, but let's pretend it added $20,000 to the case, which makes doing it ludicrous. I don't want to get into the details. So that there's a ludicrous financial argument about why you shouldn't do it. How is that kind of cost issue starting to be wrapped up into these evidence-based discussions? Because you could develop evidence on the cost, and we know that cost is a moving target over time.
Ideally, given unlimited time and resources, one could do a cost-effectiveness analysis and use that to help make a decision. In reality, that's not overly practical, and may not help too much. I think, I don't really have a good answer for you. In extreme situations, I think it is being incorporated, and that, a situation like you described is one where it would definitely be appropriate. With the kidney guidelines, they were international guidelines. They were a little, they kind of went back and forth about how to deal with costs. They wanted to talk about the ideal care, the best care, but then they had to take into account costs because it's such an important issue in other parts of the world. Middle-income countries specifically.
Important everywhere.
Yeah, but even more so. Could you even afford the steroids? Never mind robotic surgery. Sure. So I think that's going to be for your society, for the work group to consider. If the costs between different interventions are not a major driving factor, then it's probably not.
But could you just add another row in your table and say adverse outcomes, and the last one is cost, and you can factor that in? Obviously, cost in third world countries would be more critical than here,
Yeah, there could be other considerations or even explicitly a cost.
Well, we have to decide the scope of any particular guideline, and as we write a guideline, if we decide cost is within the scope of what we want to do, then we'll add it, and if not, we won't.
That's just a bit of a philosophical question. So when you said, what are we grading, and you talked about the quality of evidence, the confidence that the estimate of the effect is adequate to support decision, and strength of recommendations, the extent to which we can be confident that following recommendation will do more good than harm. But does anybody twist it around and say we'll do more harm than good? Then it gets to the cost for your robot. So we're reasonably confident because of the cost implications based on, because, if they're equal outcomes, but the cost is, I'm saying as an example, exponentially higher for the same exact outcome.
Yeah.
It doesn't, are we reasonably confident that does more harm than good? Because if you're only looking at it from good versus harm, and you only have two choices, strong or weak, then it kind of boxes you in. Has that been discussed?
Well, this definitely gets at the issue of perspective. Most guidelines are written from the perspective of the individual patient or maybe clinician. But I think it's perfectly reasonable to take in societal perspective also. So if you're spending $20,000 on a robot, then you're not spending it on vaccinations. Or even in a hospital, you're not spending it on, building the outpatient center clinic.
But if you only have, let's say the question is, does robotic cholecystectomy improve, however you put it, what does it improve outcomes for patients? And you review it, and the outcomes are pretty much the same, but your choices are only strong or weak about doing more good than harm. So you either can make a strong recommendation, we strongly recommend it because it does more good than harm, or we weakly recommend it because it does more good than harm. Those are your only two choices.
Or you, yeah, exactly.
Okay.
Or you don't make a recommendation
Right,
about
we
it.
don't make. Okay. Thank you.
Just to continue with this example, so that's the recommendation, the table that fills out the recommendation itself. This is just one brief summary of the rationale for that recommendation, and then actually a longer description of the evidence base itself after this.
Yeah, I think we have in some of the guidelines made really long summaries of the evidence, and this is a better way to do it as a paragraph and then include the table.
Yeah.
In the publication.
I mean, just a brief synopsis describing the rationale for each recommendation really helps users of the recommendations.
So as a aid to publication, is it possible to say, for instance, that the appendices that include all the tables are available online?
Because that was table 22, I noticed. So there's
Yeah.
100 probably.
Well, like I said before, this was from the kidney guidelines. Yeah, this was all in one supplement for a journal. So this whole guideline, this was on glomerulonephritis, and it was endless. This is hundreds of pages. It has everything. I think on top of that, there were also supplements. I'm not suggesting that you need to go into that level of detail and completeness.
There's a question about that as well. There's a lot of this, at least the systematic reviews, have those lovely diagrams with the box plots and the confidence intervals for every outcome.
The forest plots.
Yeah. So, is that something, we spoke about that before, is that something we should be including in our guidelines, or that specifically part of a systematic review? And where's the crossover for our type of society?
Well, let me start with saying, first there'll be, a discussion about which comparisons, which outcomes would it be of interest to maybe meta-analyze them. Then looking at the evidence, seeing if it's really amenable to meta-analysis. If it is, and meta-analysis is done, there will be a forest plot that shows each study of the results of each study and the summary. And that will be available. Where exactly it goes is a different question. If you have a separate article for your systematic review, then it would go into that. If it's a combined article and it's thought that it's important to highlight, this recommendation is based on this meta-analysis, and this is showing some interesting finding, then it would be reasonable to include it there, or maybe as an appendix.
So it is perfectly reasonable, and I've had this thought many times to say that the heavy lifting in terms of meta-analysis of this particular outcome or this particular group of outcomes has been done within the last year, and that there's been no appreciable change in the evidence, and here were their findings that we're basing our recommendation on. Is that?
Yeah. So part of the search for the literature on a new topic will be to look for existing systematic reviews.
Right.
And if there's a recent one that the work group agrees was well done and covers the issue, there's, maybe update it a little bit, or maybe just take it at face value use that to form a recommendation and move on.
There hasn't been a full meta-analysis done on that, is that?
Well, that's not I mean, that's certainly not a requirement that a meta-analysis be done, and again, particularly in surgery, I think in most cases, the evidence is not really going to be amenable to meta-analysis, so it certainly would not make that a requirement. Just as a sort of counter example from another kidney guideline, this is hepatitis C infected patients on maintenance hemodialysis. Monotherapy with standard interferon that is dose adjusted is suggested as a weak recommendation. Kind of going backwards. It's probably even harder for you to see. But, well, we were using very low back then. Well, it's kind of, there's no evidence about survival, which obviously is a critical outcome. And there was also, it should be in here, but there's no evidence about liver failure either. Basically, this is all based on sustained virologic response, which was a highly important outcome, it was thought, but still recognized as very much a surrogate outcome that doesn't necessarily relate to how patients do clinically, and that's why they made it only a weak recommendation, suggestion. Okay, so I've talked about this. One of the first steps will be to determine the important, well, after the research question is fully defined and all the issues are determined, what part of that process is determining which outcomes are of interest. Once we have that list, we'll want to prioritize those outcomes. I will argue that they should be prioritized from the perspectives as best we can judge of the patients themselves and families and so forth. So I know I get a lot of pushback from the gynecologic surgeons because estimated blood loss is not particularly important to patients. A lot of the intraoperative measures are not particularly important. Length of hospital stay, I would argue, is also not really that important. So a lot of the outcomes that a lot of the surgical studies really focus on are arguably not that important.
I mean, it's important that you have to get a transfusion. That's
yes.
Really important.
Yeah. That's on the list of importance. Although it's less important, if there's no repercussions from that transfusion, then again, it's not necessarily
that's
all that important.
Yes, you're a Jehovah's Witness, and then it's changed.
Well, but I mean, just in terms, we all know that. Like I said, I don't want to get into it, but
no, I mean, but I mean,
well, I guess what I'm saying is that there's a reason because the weight of those untoward outcomes in the operating room, say like the length of time in the operating room. If you're a surgeon whose length of time in the operating room for a given operation is 2 standard deviations above the norm, that probably does affect patient outcomes in the long run because it causes additional problems in the post-operative period.
He's just saying to the patients, patients don't care if they're in the hospital a little bit longer for the most part. But your hospital administrators do. Yeah. It makes an effect on the cost.
I'm also not saying that things like estimated blood loss and length of stay should be ignored. I'm just arguing that they are of lower priority than the patient-centered outcomes of what their level of pain is post-op, when they can get back to work, when they can resume a normal diet maybe.
It's interesting though, if the patients knew that their wound infection rate would go up the longer they stayed in the hospital,
their chances of pneumonia or something.
It might become something of interest.
So I mean, their judgments.
I guess that's what I'm saying is that they don't necessarily understand how these measures impact their outcomes. That's what I'm getting at.
Again,
they don't care about it because they don't know that it matters.
I'm just saying, I'm just making the argument in terms of prioritizing the outcomes, it's not as high a priority.
Well, and we've had a
is-
problem with that, I think, that we are only just beginning to address that in surgery, where we're actually thinking about thinking about outcomes in terms of how the patients are affected. I mean, we've always been very, selfish or self-centered in terms of how we think about what we do. And it's only just moving to where, and that's going to, so I guess what I'm saying is that looking at outcomes in terms of things that are important to patients, that's kind of new.
Yeah, no, it's new throughout, the whole medical world. It's not just to you guys, certainly.
How do you know what's important to patients?
Well, the real way to do it is to get the patients in, to ask them.
To do that kind of qualitative work, to really do it in a high level is a real thing.
It's a challenge,
It's not just having a couple of patients at your guidelines or reading the guidelines. I mean, I think it gets like you get into a bit of a, we're still judging at the end of the day what that patient, and probably as a patient will say, my recovery from my surgery, getting back to work, as you said, is important. But we could say that length of stay is a surrogate for some of those patients' symptoms in hospital, for example. So you can get around it a little bit.
Yeah.
It's just
So from a practical issue, it's going to end up being the work group's consideration of what is most likely important to the average patient, and also considering that issue when determining whether there may be differences based on patients' preferences, values.
I don't want to stop the flow here, but we have just over half an hour more. Oh, no, yeah, just over half an hour more. We've got to go to the president's talk at 10 o'clock, so.
Are we doing okay from your perspective?
Just want to make sure that we get the most important.
I knew this would take a while, but I mean, we've been having some great discussions, so it's, okay, so this is what we've been talking about. So you can see, outcomes of interest, dollars, costs is on there. Okay, I've talked about these. Okay. This is still going through the grade table. The studies themselves will be individually evaluated for quality, risk of bias. These are some of the issues that will be considered. We'll try to use some standard methods for assessing the risk of bias. We'll use the Cochrane risk of bias score, which covers these issues here. And we'll add some additional questions to that. There are also scores well, I shouldn't use the word scores. There are lists of questions, risk of bias questions for observational studies that are pretty standard. So we'll include those. Have the work group members evaluate those as they're extracting the data.
Just a very good question. Since I tweeted out Schweizberg's question about whether or not cost should be included in guidelines, already getting some tweets back. And I just raised a question that maybe in our guidelines there should be some value component of our guideline, which is outcome divided by cost.
We have a value committee that does that, and I think we have, you gotta guard against, it's not a bad idea.
No, I'm just
but I think we have to guard against mission creep, I mean, I don't know how the meeting started, I apologize because I wasn't here, but our focus is that we have a large membership and we need to serve our patients and our members. We need to improve our visibility in the quality landscape because we want to be the go-to organization for our specialty and the things that we know about for regulators and insurers, policymakers, and we need to tighten up our time frame. So instead of a project taking 2 years, we need to get things out every 6 months, 8 months, something like that. So I would suggest that you three, tightly define the scope of this project and avoid mission creep to enable to get the turnaround time down, get the methodology down, get it to be very precise, and take already well-respected documents and make them as good as they can be. And then if you want to start working with, quality and tech evaluation and all of that to sort of see what other components can be wrapped into it from a cost perspective, then that might be a better way to go.
Yeah, I mean, I think to answer your question about how you make this more visible and more useful, as I really thought about that with Steve's question, it really made me, this first time I've ever thought about that, that might be something that really makes our guidelines even more useful out there, is to include a value proposition of our guideline. Not necessarily mission creep, but that may be something that is helpful, just as a thought, so.
No, I
But I agree with you.
You know the data set really with the cost is really
Right.
complete.
And I think that Rob's comment is really important about what the focus of this meeting is exactly trying to figure out how you can help us really get our guidelines quicker, more appropriate.
Right. Okay, working through the grade table some more. The next one was inconsistency. In addition to judging whether there is a consistency, when there is inconsistency, this is a standard goal of systematic review, is to try to look for an explanation of that inconsistency. Are there different findings in different sets of patients? Were there some specific details about how the surgery was done, the intervention, that can explain those differences? If an explanation like that is found, and sometimes that's through subgroup analysis and so forth, then that may change the wording, the recommendation, such that you say, in this situation, we'd suggest this, but in that situation, it's not clear what the appropriate treatment is, something like that. But in general, inconsistency would decrease the confidence in the effect. Indirectness, I've talked about this. Surrogate outcomes also are considered indirect. This is someplace where I find grade a little bit difficult because you're judging for a specific outcome, and then you're saying that outcome is indirect for that outcome, but what you really mean is it's indirect for patient-centered outcomes, let's say. So, the outcome may be hemoglobin A1C, but that's not really what you're interested in.
One of the common issues we're having is we may have good outcomes, but the follow-up period may be limited. Is that being taken into consideration here, and under which aspect? So if you have, let's say, 2-year follow-up versus you'd like to have 10, because they may be different, and oftentimes they are. Does that decrease your somehow?
Yeah, that's definitely an important consideration. Where, I have to think a little bit about where to kind of drop that in, but for some of it may be more important issue for some outcomes than for other outcomes also. But follow-up time, setting. When the study was done, is a surgical trial from the 1980s, how relevant is that, in 2015? Those are other types of issues, and there are lots of them.
Our achalasia guideline just got cited by a poem manuscript in gastrointestinal endoscopy. I'm glad to know.
Okay, let me see. I'm going to skip over some of this stuff. Okay, I think we talked about this. Large effect size increases the confidence in equality. Dose response. I've never seen this actually in practice, but if all the confounders one can think of would only strengthen the association, then that would increase one's confidence, but it's probably too theoretical to be meaning. I'm just quoting from grade. Okay, I think I was giving another. Okay, let me just talk a little bit more about values and preferences. So this was, again, hepatitis C in dialysis patients. That's what the whole guideline was. Well, actually, it was hepatitis C in people with chronic kidney disease. This chapter was on dialysis patients. So there was just some discussion about, actually, okay, sorry, let me go back a bit, do this in proper order. So the evidence, the quality of the evidence was very low. The balance of potential benefits and harm was that there was improved sustained viral response compared with untreated patients, but no information on critical outcomes, including mortality. In addition, there are significant but self-limited adverse events reported. So basically, good evidence for sustained virologic response, but no evidence for survival. And there are some harms, although they're not too major and they're self-limited. So the considerations that the guideline group went through was if a guideline work group values sustained viral response highly because it considers it to be a good surrogate or proxy for better survival and quality of life, and it de-emphasizes the adverse events because they're usually self-limited or manageable, it may issue a recommendation on the treatment. However, if they judge the benefits of the SVR to be uncertain, and they're more concerned about proven harms, it may issue a weak recommendation against the use of treatment. Alternatively, the work group may recommend treatment only in a subgroup of patients where the benefit to harm ratio is most favorable. And there's an example of who that might be. Or they may refrain from making any recommendation because there was no consent. So this is all just an example. We talked about this earlier, that the same, a body of evidence can be interpreted differently based on the overall judgment of the work group and trying to incorporate different stakeholders' perspectives, different clinicians and patients' perspectives.
Presumably this comes out in the discussion text.
Yes. Okay. So, and this goes down to the patient. If optimistic, hopeful patient says, this might cure my hepatitis C and make me a better transplant candidate, which is really very important for people on dialysis, he may decide to take his chances. But if the patient's more concerned that they're going to be miserable for 6 months because interferon basically gives you the flu, if you remember, for as long as you take it, or flu symptoms, I should say, and you don't know if it's going to do anything for me, then I don't want this. So, the recommendation may be to suggest to the patient, present to the patients the benefits and harms and have that discussion. And then there's the old parachute, the opposite extreme, the old parachute effect. There are going to be interventions, choices, decisions. You don't need a trial for it. You can make a recommendation because it's the obvious thing to do. Although people do survive falls without parachutes.
Don't want to try it.
Okay, challenges. We've talked about a lot of these. These are always going. There's always going to be a level of judgment and interpretation. Transparency regarding the group discussion is the way to deal with that. The work groups are going to deal with a lot of surrogate outcomes. Not all of them are going to be good surrogate outcomes. They're always going to be susceptible to misinterpretation and error. How to deal with them, but they may be the only outcomes you really have. Harms can be judged Judgments, harms are badly reported. Studies don't report adverse events very clearly. There's a whole range of harms. The work groups will probably end up relying a lot on observational studies. They have their own host of quality and bias related issues that are sometimes hard to overcome. Evidence is often inconclusive. GRADE and other groups generally suggest that recommendations be made even in the face of lack of evidence. It's usually more helpful for clinicians and et cetera to have a recommendation in front of them they can follow than to just be told, well, we don't know what to do, so do whatever you want. You guys or the work group hopefully will be the experts, the world experts in the field, particularly related to the evidence that they just reviewed. So they should be in the best position to make a recommendation. I don't know why I have diagnostic tests on that list. I don't remember what I was going to say. We talked a little bit, it's about using existing systematic reviews. I think it's perfectly appropriate. The problem often is that the reviews may not have been very well done, or they're not addressing quite the same issue. They may not be giving an assessment about the quality of the studies, so it's sometimes problematic to really use those, but it saves a lot of time and effort, certainly.
We've been asked also, again, for certain of our guidelines to look and see if there are other ones already available that we can just co-endorse.
Yeah.
For instance, we had written one on DVT and PE prophylaxis a number of years ago, and the CHEST guidelines are actually very well written. So at the time that we did it a long time ago, the guidelines available didn't really outline what to do in laparoscopy. But I think that CHEST guidelines probably do now, so we were considering just co-endorsing those guidelines.
Yeah, that's a good point. I mean, I would say use existing guidelines also in addition to systematic review, where appropriate. Okay, we talked a bit about, well, we talked a fair amount about conflict of interest and group composition. Grading, there's usually very little, if not no, evidence regarding complex patients, which for many fields ends up being the bulk of the patients you see, or at least the patients who have the most questions about what to do are the complex patients. But the evidence isn't there, and it's probably likely that your recommendations will not end up addressing the complex patients very well.
We had this discussion at our meeting a couple of days ago.
Yeah. What do you do if the evidence is not definitive? Choices, I'd rather not recommend anything until I'm sure about what is right, or I would rather give some direction in the hope that it may help. Like I said, the IOM and others, and myself, kind of lean in this direction. But that doesn't mean that you should be writing recommendations about everything. Okay, I'm ending with this slide here, mainly to just remind us again that the guidelines are part of this continuum. Performance measures, again, will be developed out of them. I would say that you guys have an opportunity to develop your own performance measures based on them. And this should also lead back into future research issues. Gaps in the evidence will be found and should lead to more research and more evidence to help support future updates of the guidelines. So that's all I have about, 2.5 hours later of what I have about guidelines. I can talk a bit more about the systematic review process also, or we could have some general discussion.
How about you go over a bit the tools that you use and how they help?
Okay.
Like the abstract, for example, you just put that.
Yeah, so the two tools that we use, one we will definitely use, one we'll have a discussion with. It'll depend a bit on the evidence and so forth. Are systematic review tools. For the guideline development, I mean, there are, you mentioned there is a tool out there to build a grade table. I find it infinitely easier to pull up a Word document, create a table, and fill it in than trying to use their tool. The two tools that our group has developed and that we use and are being used widely are, again, they're for systematic review. One is for helping in the process of screening through abstracts. Is everybody here at least familiar enough with the systematic review process to know what I mean when I'm talking about screening through abstracts?
Yes. I think most of us
Except the newest members, it probably does.
But can you tell us how?
Yes.
How can we make that process easier?
Right. So it'll make it very easy. The second tool is a tool for actually helping to extract the data out of articles into a standardized structure format that we can export data out of them to help to create tables, and also will be placed into a repository which will be made publicly available, so it helps with transparency.
Going back essentially to the outcome table you showed us earlier, is that what that tool allows you to do?
No, that was the great, it will help to create.
Or is that the way you put each study in and its level of evidence?
Yeah, so it would be study specific. Oh, that's very short. Well, it will help to create the summary tables, which will give the description of the study design, the population, the interventions, the outcomes, definitions, the quality of the studies for each individual study.
This tool is just a tool that's marketed or
something? No, they're both online. They're both publicly available and free. The abstractor tool for screening abstracts, anybody can just, you just create your own username and password and you're in. The SRDR, which is a systematic review data repository, the data extraction tool, it's online, freely accessible, but to get in order to input data to extract into it, one would need to register. We'll have a training session if we decide to go that route.
Could you please send out all the links to those in your summary?
Yeah.
I might ask for just a 2-minute talk on what systematic review is, just to make sure I understand exactly what you mean by all these extra tables.
Okay. Well, I don't have examples of the tables, but I've got. I could pull some up, but in this presentation. But I have 8 slides here.
That's fine.
Okay, so the basis of a systematic review is to apply a standardized protocol to critically evaluate the evidence and rigorously combine the results. The important things here are that it's an a priori protocol and that there are rigorous standardized methods, so you're not just ad hoc including or excluding studies.
After the fact, after you start.
Well, after the fact and during the process. The idea here is to minimize the reviewer, minimize the impact of the reviewer's biases on the selection of studies and the extraction of evidence.
So what we tend to do is we choose, say, the last 5 years and do a literature review. But then we do a manual search if there's a landmark paper from 25 years beforehand, or there's an expert opinion. I think all of our guidelines refer to that, even if they're outside the search criteria, we track that.
Well, that's added, that's
Yeah,
part
so
of that's not really.
So that's not part of the systematic review. that would be something that would be added on to the systematic review during the next stages.
When we write what our search criterion are, we put in what our search terms were, and we state specifically that when other articles are found through these articles that we have added them. That's part of our search criteria.
Yeah, that's what I'm saying. Is that acceptable?
Well, that would be, again, something in parallel to the systematic review. If you want to include a 25-year-old study in your systematic review, then I would argue that you need to go back and find all the studies that have been done in the last 25 years. So you're not just cherry picking that one article. The concept of the systematic review process dismisses the whole concept of there being a landmark study. You may find that study and judge it to be of better quality, with fewer biases, with greater impact, larger study. But all the other studies, at least coming in, have equal potential value.
I think in general, I don't recall having an example like that, but sometimes our search terms don't find relevant articles within our search period, and that's why we do add some of those articles.
Well, part of the review process is to do the search, find the articles, consult with experts, hopefully the work group are those experts, to add in missing articles, look through reference lists of review articles, add in articles. Ideally, go back to your search, fix your search so that they would have found those articles, find any other articles that are similar to those that were missed the first time around.
An example I can think of is, I think, from the parasophageal paper, whether we include a fundal publication or not, but we went back to some Allison's data and many years ago, and that was well outside our initial search criteria.
Yes, but I think we're talking about two different things. We're talking about search strategy, and where the review starts is after you're happy with what you found. So what he's saying is, once you start the systematic review, don't start adding studies after that. You already have selected what you're going to do.
Yeah.
Whether you look at the literature, whether you go back, you do the search.
You don't want to change the scope.
But for parasophageal, that would have been going from 500 articles in the last 5 years to 10,000 articles for the last 25 years. And
well, that's one of the problems
well,
with systematic review. You need to go through a lot of.
Maybe the abstract thing helps.
Screening through. I would expect that the work group will screen through 2,000 to 5,000 citations. If you're screening through fewer than 1,000, your search probably is not broad enough, unless it's a very focused topic. That doesn't mean you're going to be going through 1,000 articles. It means you may be reading a couple hundred articles and then finding that 20 to 50 of those meet criteria.
That's already a significant change.
I'm just throwing numbers.
Because what we did for, say, the diagnostic laparoscopy guideline, we did have that many articles, and we read through the abstracts, and from looking just at the abstracts or the number of patients, and certainly was one of our criteria was the number of patients. We shot out a number of those articles just on the basis of
All right,
that.
can we limit the discussion so we can go through this? Otherwise, we don't have time.
Okay. So systematic review provides qualitative and quantitative summaries of the overall effect, and the quantitative are the meta-analyses. I've talked about explaining differences across studies. There's lots of different reasons to why studies differ. It evaluates the strength of the evidence and guides future research. I've talked about those. The first step is to formulate the research question. First step of any research. Determine the study eligibility criteria. That is based directly off of the research question. The research question will include who the population of interest is, what the interventions of interest are, what the comparators are, what the outcomes of interest are. The eligibility criteria will replicate each of those items, define them more thoroughly, add in what are the study design issues of interest, maybe what the publication year is, other issues. There's a systematic search for all those potential articles that may be eligible. And we will definitely help to to write essentially the code to find those studies, and we'll run the search for you in Medline, Cochrane, other databases as relevant. We'll collect all those studies together. Actually, there'll be an EndNote. We'll transfer them into Abstracker so that people can go to that site, see each abstract, and make a decision whether to include or exclude. That will be done in duplicate, so 2 people will be looking at each individual article. Where there's disagreement, where there are conflicts, those would be resolved through some process. All the articles that are accepted by consensus are then retrieved in full, and each of those full text articles is again reviewed by 2 people independently, and using the eligibility criteria, and then you have your final set of studies for inclusion. We'll develop a data extraction form that will either be in the SRDR, or we may do it more simply in Excel. We'll have some discussions about what's easiest and most appropriate. Each article will be systematically extracted. The idea here is that you're not just reading through an article and picking out and making a kind of general thought about whether this is a good or bad study, what they did, and picking out the stuff that's interesting to the authors, usually. But you're actually looking to see, how did they really define this? What did they really do? What outcomes did they report? What outcomes did they not report? What methods did they not report? What, can you replicate this intervention, or did they describe it so badly you have no idea what they did? That built into evaluating the risk of bias of each study. Then all the studies will be summarized together in tables. Again, these will describe who the population was, what the interventions were, what the outcomes were, how they were defined, what the results or findings of the studies were, and what the quality was. We'll look for differences across studies. So this is what I mentioned before, PICO, it's called Population Intervention Comparators Outcomes. The population is who the people are, what their diagnoses are, what the conditions are. We'll have some long discussions to figure out who exactly is of interest. Long discussion about what the range of interventions are, the specific interventions, what they're being compared to, which outcomes are important, not important, and can be ignored, what study designs are most relevant. Okay, so this was, there's lots more detail. This is just one example, stress urinary incontinence. Of each of these factors is delineated, and then when you're reading an abstract, when you're reading an article, using these criteria can decide whether it's relevant or not, whether it meets criteria or not. In a couple of, let's see, how do I shrink this down so it's actually can be seen? No, this is the screen I want. I just want it to be where it's good enough. Okay, this is the Abstracker site. When people log in and they're given an assignment, they'll see a page like this. Okay, let's see. Hopefully this will. Yesterday there were some abstracts still to be screened in that group. Somebody got busy overnight. this will fit on one screen. Actually, you could do this on your iPhone really easily. It works really well. I screen on the train in the morning. So you'll see the title, the authors, the full abstract, keywords. You can color code things. So sorry. Do that again. Okay, so you can put in terms that are, I just picked random words, but that are relevant, or maybe that can help you decide that this is not relevant. So if you have a lot of animal studies, you can put in a list of animals. And this will carry through for all the abstracts in your set.
So you can find it easier when you look.
Yeah, so this helps in the screening process. And then you accept or reject, or you can also say maybe. And it'll pull up the next abstract and move on. And then everything can be downloaded as an Excel file, and we'll see which ones there's consensus of agreement. We can pull up conflicts and go through conflicts. So this is a really easy thing. People can do it anytime they're connected to the internet.
Thanks, Ethan. This has been extremely valuable. There will be a session from 1 to 3 o'clock. Is that also here?
It's Chitford Road.
Chitwood Road, wherever that is.